A group that are at high risk for relapse. In adults, we have not been very good at keeping these patients in CRs, and the 5-year survival rates are relatively low at 40 to 45%. Diffuse large B-cell lymphoma that relapses after autologous transplant with chemoresistance disease has a relatively poor prognosis as well. So in regards to acute lymphoblastic leukemia, this continues to remain a challenging disease to treat in adults, with cure rates of only 20 to 45%. And the AYA, or the adolescent young adult acute leukemia, continues to cause about 30% of cancer-related deaths among patients less than 20 years of age. Based on data from the LALA-94 and the MRC, adult patients' outcomes after first and second relapse, the prognosis is relatively poor, 5-year survival rates of only 7%. Even with the advent of targeted therapy with tyrosine kinase inhibitors for both Philadelphia-positive ALL and pH-negative like ALL, the prognosis for relapsed ALL remains poor. So both the American and the European expert panel's recommendations for allotransplants in adults recommend that first remission patients with high-risk disease, Philadelphia-positive or pH-negative like ALL, who have poor risk cytogenetics, who are unable to achieve a remission, or remain MRD or minimal residual disease positive and have a subsequent CR2 relapse are indications for transplantation. If we look at the outcome in regards to transplantation, CIBMTR data in unrelated donors, it's significantly improved over the years. If we look at the data from 1987 to 2016, survival has changed from 30 to 60% over a 2-year period. The majority of that survival advantage has improved in regards to not only antifungal, antiviral therapy, but also supportive care. Our regimens in regards to conditioning have not relatively changed per se. So allogenic transplant remains an important post-remission management of ALL, but again, proper risk stratification is a major challenge. Incorporation, most recently, of MRD testing, molecular testing, has improved patient allocation. Allotransplant, again, is the most purest form of immunotherapy, and the fundamental immunotherapeutic strategy which we aim for is increasing the GVL, or graft versus leukemia effect, while avoiding graft versus host disease. Again, there's a kind of a seesaw approach to that, but in regards to management, a little graft versus host disease, grade 1, avoiding grade 3, 4 GVHD, which again has a difficult response in regards to corticosteroids. So what is the data that supports ALL in first remission? So the UK ALL, or E2993 study, was the first large ALL study in the role of a match-related donor. Patients underwent transplant in CR1 donor versus no donor, was assessed in pH-negative patients. The 5-year overall survival for those with the donor was 53% versus 45% without a donor. Relapse rates were also significantly lower in the population that received the match-related donor in both the standard risk and the high-risk disease groups. The HOVON study also evaluated the role of match-related donors. In CR1, 5-year incidence of relapse was 24% for those patients who underwent allogenic transplant with a donor versus 55% for those without a donor. Non-relapse mortality for the transplant group was 16% at 5 years. So who should be considered in patients who don't achieve an MRD negativity, have high-risk cytogenetics and molecular features? Philadelphia-positive ALL and Philadelphia-negative like ALL remain standard of care in regards to receiving transplantation. Pre-treatment cytogenetics in the era of MRD, complex karyotype, the HOTR cytogenetic abnormality are adverse prognostic factors in which transplants should be considered. If we look at we don't have a pointer yet, correct? Okay, that's all right. So if we look at the data in regards to, maybe I can just do it on the screen. Okay, here we go. I could just, here, pointer. If we look at the patients with high-risk cytogenetics or greater than 5 abnormalities, they relatively have a poor prognosis. And if we look at the HOTR, the MLL gene rearrangements, again, prognosis is poor with significantly poor outcomes. When we look at the data from ESA, et cetera, all reported in cancer, MRD positive disease versus MRD negative. Obviously, patients who achieve MRD negativity have a better outcome. So CR rates of chemotherapy regimens for adults with relapse refractory ALL remain low, 30 to 40% for the first salvage therapy. After an early relapse, merely 18 to 25% of those patients will respond to a second salvage therapy. Salvage allogeneic transplantation has been one of the therapeutic options for these patients prior to CAR T therapy who have not obtained a CR. However, high relapse rates after allogeneic transplant is still an unmet challenge in this patient population. Minimal residual disease positivity at the time and after transplantation remains a major risk factor for treatment failure in our patient population. Barr reported the outcomes of pre- and post-transplant MRD positive patients in 160 patients. 3-year overall survival in patients who obtained MRD negativity was 68% versus 40% for those who remained MRD positive pre- and post-transplant. So in regards to the rates of relapse, obviously patients who were MRD positive had high rates of relapse post-transplantation, and those who achieved MRD negativity, overall survival was statistically significantly better. So again, we said that this remains a challenging disease in the adult population. The mortality and even the AYA population is high, and even with targeted therapies, the outcomes remain poor. Why does this differ so much in regards to the younger pediatric population where cure rates are 80 to 90%? Because a lot of the adult population has or harbors poor risk cytogenetics. 25% to 35% are Philadelphia positive. There's a high rate of Philadelphia negative ALL, especially in those over 40 years of age. In the adolescent young adult population, the MLL rearrangement, KM2-2A, AFF1 were found in about 13% in the GRAIL-R study. And again, the Philadelphia-like, which encompasses the AKZF, CRLF2, and JAK2 pathways, have a high incidence in the AYA, and again, that 40-year-old population. Those have been associated with, again, high rates of treatment failure, high rates of MRD positivity after induction, and a poor response even to salvage therapy. So over the past 3 years, there's been 3 new FDA-approved agents. The first is Blincyto, or blinatumomab. It's a CD319 conjugated BiTE that was approved in December of 2014. In the relapse setting, however, the median overall survival in that patient population is 9.8 months. Inotuzumab ozogamicin is a drug antibody conjugate anti-CD22 with calciumycin that was approved in August of 2017. In the relapse setting, the median overall survival was 5.1 months. And then again, obviously, the CAR T show began with the ZUMA-1, the ELENA, Juliet, and Transcend trials. So if we look back to 2012, the first patient, a pediatric patient who was treated with CAR T was a patient called Emily Whitehead. She's pictured here at the FDA advisory board, and she's now greater than 5 years cancer-free. She was the first patient treated at CHOP. She was on one of Dr. June's and Grubb's patients. She developed CRS as a complication requiring ICU admission. She was found to have IL-6 levels greater than 1,000-fold, and was the first patient who actually was treated with tocilizumab. The story goes that Carl June's daughter had received tocilizumab for rheumatoid arthritis, so we saw the levels of IL-6 and tried this agent, and it actually worked quite well. Probably saved her life. Currently, she's greater than 5 years post-CAR T therapy, and again, the ELENA trial was what that was based on. That was the single-center phase 1/2A study on 60 patients performed at CHOP. The CR rates in that trial were 93%, and again, those patients had greater than 5% myeloblasts, leukemia blasts at the time of therapy. So again, the single-arm open-label global phase 2 study in 75 patients at 25 centers. So this study group traveled around to all these. There was a nice paper describing how they traveled to each center, spent all this time getting this therapy going. It was a lot of work. But these patients were aged 3 to 21. They received Chimera or telangiecel that was generated utilizing a lentiviral vector. so that the CAR contained a CD3 zeta and a 4-1BB costimulatory molecule. So that was a picture I showed of that second generation CAR. All patients, again, had greater than 5% lymphoblasts at the time of screening, median of 3 prior therapies, and in this group of 75 patients, the median marrow blast was 74%, so a very large volume of disease. 61% of these patients had a previous stem cell transplant that underwent CAR T therapy. The results of this trial, with a median cell dose of 2 to 5 times 10 to the 6 CARs per kilo, lymphodepleting chemotherapy consisted of fludarabine, 30 milligrams per meter squared for 4 days, Cytoxan 500 milligrams per meter squared for 2 days. The response rate at 6 months was 80% and almost 60% at 12 months, with an event-free survival of 73% at 6 months and 50% at 12 months. This was led to the approval of this therapy, treating patients with ALL up to the age of 25 in 364 days. How about adults? What's the data on adult patients? So the majority of this data comes from Sloan Kettering, Park, and then the Fred Hutch. So Park, this was published in New England Journal, looked at 53 patients aged 23 to 74. 36 had 3 prior lines of therapy. 19 of these patients underwent stem cell transplant. 12 patients had primary refractory disease. The median blast count, again, very high, 63%. In this patient population, there was I think it was 16 almost were Philadelphia positive as well. So the results of this study among the 53 patients treated, median follow-up at 29 months. Some of this data is a little bit more mature now. Event-free survival was 6.1 months. Median overall survival, 12.9 months. Long-term follow-up of these patients confirmed 2 things: that potent anti-tumor effect and efficacy of the 1928 CAR. These patients induced a high rate of MRD negativity, CR, among heavily pretreated adult patients with relapse refractory leukemia. So the question is always, how does stem cell transplant fit in if these patients are able to get into an MRD negative role? Do they benefit? There's been really no statistically significant benefit of transplanting these patients post-CAR T. However, when we look at the results and the summary of CAR T in regards to adult and pediatric patients, the majority of these have relapsed after allo. So from Sloan Kettering, 53 patients treated, CRs of 44 out of 53 patients, Fred Hutch, 22 of 26 patients in CR. Pediatric data, again from the CTLO-19 or the Elena study, 6-month, 9-month relapse-free survival, and overall survival ranging from 75 to 79%. NCI reported 65% overall survival at 6 months, and Seattle 70% overall survival at 12 months. So one other caveat in regards to utilizing induction therapy with CAR T-cell versus utilizing chemotherapy as salvage for these patients with relapse refractory disease. So we recently looked at this in the Annals of Hematology 2018. They did a case control study with conventional chemotherapy, and obviously these patients were followed for 1 year and was statistically significant in regards to conventional chemotherapy salvage versus CAR T therapy in patients with relapse refractory disease. How about high-grade lymphomas? So non-Hodgkin diffuse large B-cell lymphoma occurs in about 20 to 30,000 cases annually. This encompasses the other aggressive lymphomas, and these have a poor prognosis if they are not cured with conventional chemotherapy. Autologous stem cell transplant has a significant role and has long known to improve both progression-free survival and overall survival among patients with diffuse aggressive non-Hodgkin's lymphoma, especially in second remission. Patients with chemosensitive disease who are medically fit can be treated with high-dose chemotherapy followed by autologous stem cell transplant, and as we know, this offers long-term remissions. However, in patients who relapse within 1 year after autologous transplant or have refractory disease, and never make it to transplant have a relatively poor prognosis. And when we review the retrospective analysis of the SCHOLAR-1 trial, 861 refractory or relapse patients had a 26% objective response and a 7% complete response to their next line of salvage therapy. Transplants performed for diffuse large B-cell lymphoma in the presence of active disease have a relatively inferior outcome and a high rate of relapse, depending on the salvage therapy response, CR, PR, or no response prior to transplantation. What about allogeneic transplant in patients who relapse after auto? So this has a definitive role in patients who are medically fit to receive this therapy. It is considered a therapeutic option for high-risk patients who relapse after auto. Advantages include a tumor-free graft and a graft versus lymphoma effect. However, similar to other transplant indications, improved relapse-free survival can be offset with high rates of transplant-related mortality. These patients have received multiple lines of chemoimmunotherapy, and again, their ability to tolerate high-dose chemotherapy followed by transplant is less than adequate. Based on the Gitmo study, patients who are able to respond to salvage chemo have a match-related donor and have a reasonable medical fitness. Their 3-year overall survival and progression-free survival is about 39 to 32%. For patients who are unable to achieve a PR or have no response to salvage chemotherapy, overall survival remains poor at 10%. In this patient population, transplant-related mortality is high, especially in the unrelated donor setting, and 25% of these patients died from progressive disease. Mortality was significantly associated with disease status at transplantation. If patients were not able to respond, had a PR or less than CR, outcomes were relatively poor. How about CAR T therapy for this group of patients? So if we look at the two FDA products and the Lysocell as well, all of them have a TCR signaling domain, that's CD3 zeta that I spoke to. Co-stimulatory molecule differs with the exa-cel versus the Chimera CD28 41BB and the Lysocell. The Lysocell is a little bit different of a product in regards to CD4, CD8. However, again, both have the co-stimulatory antigen and the TCR signaling domain. So CAR T therapy for diffuse large B-cell lymphoma, if we look at the ZUMA-1 trial, the Juliet, and the Transcend, all of the trials use lymphodepleting chemotherapy containing fludarabine Cytoxan. The cell dose ranged from 1 × 10⁸ to 5 × 10⁶. Overall response at 6 months for the ZUMA-1 was 41%. CR at 6 months, 36%, and overall survival, 52%. Grade 3 CRS was reported in 12% of these patients, with 94% developing some grade of CRS or cytokine release syndrome. The Juliet trial, the N of 147 patients, 37% overall response at 6 months, 30% CR at 6 months, and again, grade 3 CRS of 23%. The Transcend, they did not report overall survival. CRS in that patient population, grade 3 was 0%, 24% did develop some degree of cytokine release syndrome. Cell dose again, 1 × 10⁸, 50% overall response at 6 months, and CR 50% at 6 months as well. So what are the indications in the era of hematopoietic stem cell transplant for CAR T therapy? So we know post-autologous stem cell transplant, based on the data when one compares allo versus CAR T, 1 year post-auto, patients would significantly benefit from CAR T therapy. Patients who are not able to achieve a CR or PR following their first salvage with refractory disease would be candidates for CAR T therapy. And if the patients are not able to achieve a PR, this kind of is a gray area in regards to 25% of those patients will still respond to platinum-based therapy. However, if they have received greater than 2 lines of prior therapy, most likely would be a candidate for CAR T. So this was an algorithm that was in blood in regards to the management of these patients. If patients go into CR, obviously they do extremely well. If they have relapsed refractory disease and who do not respond to salvage therapy, those patients should be considered to be driven towards the CAR T therapy. PR and CR can be consolidated with autologous transplant. Again, PR in regards to CAR T versus autologous stem cell transplant depending on the response to that therapy. If patients relapse after autologous transplant, that would be an indication for CAR T therapy as well. This slide's a little confusing in regards to, but this O with the X through it means CAR T therapy. So again, in the relapse refractory setting, if they're candidates, they should be considered for autologous stem cell transplant. If they relapse, they should be driven towards, again, CAR T therapy. And if they have chemo-insensitive disease, one should consider chimeric antigen receptor therapy for these patients. This therapy is without undergoing some significant toxicities. The reports of CRS or cytokine release syndrome are significant. And again, there is now a stepwise approach to the management of these patients in regards to corticosteroids as well as tocilizumab, depending on the grade. So in conclusion, the era of CAR T therapy, hematopoietic stem cell transplant remains a crucial treatment modality for both B-ALL and diffuse large B-cell lymphoma. CAR T data and response rates continue to mature. They hold great promise for improvement on outcomes in relapse refractory B-ALL and diffuse large B-cell lymphoma. However, longer duration of follow-up is still needed in regards to durability of response. Management of toxicities continue to evolve and will be further defined in the future. And the FDA recently had a statement in regards to the financial toxicity. It continues to be a concern to the development of these novel agents. And that concludes my talk.